Good morning, everyone. My name is Jennifer Yost, and I'm a team member with Health Evidence. It is my pleasure today to welcome you to our series we are going today to present evidence on comparing screening tools for intimate partner violence detection. What is the evidence? So just to let everyone know that after today, the PowerPoint presentation and audio recording will be made available on Health Evidence's SlideShare and YouTube accounts, and we will hope to get those posted within a week, but hopefully even closer to 3 to 4 days. So today we are going to be talking about this systematic review and meta-analysis, and there is a link here to the evidence, which we will be posting to you for you in the chat box shortly. So if you would like to actually access the review while we are going through this, you can click on the link in the chat and it will take you directly to Health Evidence's summary for this systematic review and meta-analysis. So just a few housekeeping issues. Please use the Q&A or the chat to post any comments or questions during the webinar. We suggest that you send the questions to all the panelists and try not to send it privately to the host. But if you do, it's no worries. I will still get to see it. At the end of this, towards the end of the session, we will have a question and answer period for our presenter today, where I will read the questions aloud to him and give him a chance to respond. So please, you don't have to wait until the end of the presentation to post questions and comments. You can do so as we're going through. For the best connection, we recommend that you use a wired internet connection versus wireless. And if you do have any issues with the technology, you can contact the WebEx 24/7 helpline, and we will post that message, that number to WebEx in the chat box as well. So, and also just a reminder for the audio, the best way to hear us today is to listen through your speakers. You would just be going to the Communicate and then Audio Connection tab at the top of the screen. So we have our first polling question today, and so we're trying to get a sense of who is joining us, and we would just like to know, are you watching the session, are you joining us today by yourself or with a group? So as we see that most people, thank you very much for your responses, most people are joining with just themselves, and maybe a few people joining in larger groups. So thank you very much to all of you who have responded so far. We'll probably leave that polling question open for just another moment for anyone else who would like to respond. So a special thanks to our Health Evidence team who has brought this webinar to you today. And there's many involved to keep Health Evidence current and maintained. So thank you to our Health Evidence team. So for those of you who may or may not be familiar with Health Evidence, it was launched in 2005, and it's a comprehensive registry of reviews evaluating the effectiveness of public health and health promotion interventions. So we provide over 90,000 visitors per year access to over 4,300 quality-rated systematic reviews. So every systematic review that is in Health Evidence has been quality-rated. And when you do access a systematic review through Health Evidence, you'll get links to the full text, plain language summaries, and podcasts where available. And one of the reasons that we have maintained this registry of systematic reviews is to reach our goal, which is to, in addition to making the evidence in the form of systematic reviews about the evidence of public health interventions more accessible, but to also make it easier for professionals to use research evidence in decision making. So just some highlights in terms of what Health Evidence has to offer. Saves you time, as I've just mentioned. It is a registry pre-populated with systematic reviews about public health interventions, but it also, we've done the job and done the work of quality rating all of the evidence that's in Health Evidence. So that will hopefully save you time. We do searches and updates to the registry on an ongoing basis, so the evidence is current and also, as I mentioned, relevant to public health interventions. Transparent process, so actually for each quality assessment that's been done for the systematic reviews in health evidence, you can actually see how we came to that quality rating for each systematic review. On our website, we also have some supports available for evidence-informed decision-making, and we found over the years that our users have let us know that it is an easy-to-use registry. So this is a model for evidence-informed decision-making, and it consists of 5 components that you see in this diagram, and it's related specifically to public health. So traditionally, public health practitioners and decision-makers do consider evidence about the circles you see there: community health resources and local context, existing resource, community, and political climate in making decisions about programs and policies. But it's become apparent that considering evidence about research has been much more challenging for public health professionals. So as such, our health evidence webinar series is designed to identify research evidence for public health decisions. Next, just to share with you, is our evidence-informed public health wheel, which illustrates the steps that are involved in evidence-informed decision-making. We use it as a guide for practitioners and decision-makers to determine how to address a particular issue by systematically incorporating research evidence along with those other 4 circles of our model. So as you can see, the steps are go from defining the issue through adapting the evidence to the local context and to evaluating implementation efforts. We're going to hear today about how the presenters worked through the first 4 steps in order to help decision makers with the remainder of the 7 steps. So we have another polling question for you. So how many of you have heard of the PICOS before? So thank you to all of you who are currently responding. And we can see a few people are familiar, a few people are not so familiar with the PICOS format. So the PICOS format is a way to structure your quantitative question when you in the defined step of evidence-informed decision-making. And it involves defining what the population is, the intervention or the exposure, the comparison, the outcomes, and the setting. So you will get to see this operationalized when our presenter reviews the evidence that they have put together for us. So another polling question: how often do you use systematic reviews to inform a program or service? So do you not know what a systematic review is? And that's totally okay, and I think we'll give you some insight today about that. Do you never, sometimes, often, or always? So thank you very much to those of you that are participating in our poll. And the most common response right now is that people actually often use systematic reviews to inform program and services. So thank you to all of you who have responded. So it's my pleasure to welcome our presenter, Nasir Hussain. Nasir is currently a student at Central Michigan University College of Medicine and holds a master's degree in clinical epidemiology from McMaster University. His primary research interests include systematic reviews and meta-analyses, knowledge translation, and intimate partner violence. To date, he has contributed to a wide variety of peer-reviewed works and national conference presentations. So just before we turn it over to Nasir this morning, another question that we would like to know, and we'll be asking you get this question again towards the end of the presentation, but do computer-assisted self-administered screens lead to higher rates of IPV, inter-partner violence disclosure, compared to both face-to-face interview and self-administered written screens? So as we see, those of you, thank you so much for responding to our polling question. We have a few people who said agree, and one person so far that said strongly agree. No one has actually disagreed or is neutral about this question. So thank you to all of those of you who are responding. So we've had actually a few people now say neutral, but most people are saying they agree or they strongly agree. So thank you very much to all of those of you who are responding. So it's my pleasure now to turn the presentation over to Nasir, and thank you so much for being here today on behalf of Health Evidence, and we are excited to hear about your presentation. Nasir?
Great, thanks Dr. Yost for the introduction. So everyone, I hope everyone's doing well today, this morning, and I hope I can help you guys understand better about the purpose of why we conducted this systematic review and meta-analysis, and more importantly, about the methodologies. I know sometimes it can be tricky to understand why certain things are done and for what reason, and I encourage you guys all to ask questions. I'll answer to the best of my ability every question about the review, and if you have specific questions about how to conduct a methodologically sound systematic review, or you have specific questions on your own meta-analyses or systematic reviews that you're conducting, feel free to ask. In addition, I want to say sorry in advance if there's any technological mistakes on my end. This is a brand new system to me, so if I do make any mistakes, I'm sorry again, and I hope this runs extremely smoothly. Very well. All right, so today I'll be, oh, what's that? Let's see. Okay. So today I'll be talking about a systematic review and meta-analysis, as Dr. Yost mentioned, that speaks more towards the identification and screening strategies for identifying victims of intimate partner violence. Now, there's two ends of the spectrum here. One end of the spectrum looks specifically at the screening tools that are used. By this, I mean the different questionnaires that can be used to identify victims. On the other end of the spectrum, there's analysis into what are the most optimal methods to administer these screening tools. And that's the aspect that we decided to focus on, because we saw that there was lots of high-quality evidence coming out on that topic. However, the research was lacking. We didn't really know which screening tool and how to administer it. We didn't know what was the best way. So we decided to conduct a systematic review and meta-analysis on that topic. For those of you who don't know, intimate partner violence, or as I'll be referring to it as IPV or domestic violence, is defined by the Center for Disease Control and Prevention as the physical, sexual, or psychological harm by a current or former partner or spouse. It's associated with significant health consequences that can have adverse effects on the victim and surrounding individuals. And these surrounding individuals could be the children, other family members, your work environment. So it's pretty far-reaching. And something that I often emphasize is that victims of IPV or domestic violence are an often underappreciated aspect of healthcare. They're often overlooked, and so because and often they're vulnerable. So it's important to identify these victims at an early stage in order to treat the condition and treat what's going on, and to ensure that this doesn't happen again. There's no recurrence. So intimate partner violence on a whole, statistics suggest that 2 to 5 million women are affected every year. And most of these stats I'm going to present to you today are about women. And that's mainly because the intimate partner violence mainly occurs in the female population. In the male population, it does occur, and I want to strongly emphasize that. It's often thought that it's a female-predominant condition, which is true. However, it's also important to note that the same sorts of things that happen for women also happen for men here. However, it's just simply less prevalent. So what we decided to do, and what the stats I'm going to present today, are specific towards women. So approximately 85% of victims are women, like I said. And statistics also show that 25 to 33% of women will be affected at least once in their lifetime. And here it's important to note that it could be as severe as trauma, broken bones, or it could be less severe on the spectrum in terms of verbal abuse. And that's often forgotten, that it's a continuum. You can't just say that someone has experienced domestic violence because they've had bruises on their body. No, but there's also another side of things where verbal abuse is also counted towards this. And it's more often seen in the clinic in divorced and separated women and those with recent struggles in life. This could be things such as economic struggles. And on top of it all, the most common population we're seeing that's most recently been reported is pregnant women. And that's because pregnancy, as people may know, is a highly stressful time in one's life. So here, these women are extremely vulnerable to IPV. So what are the concerns? Why do we look at this? And the simple question is that most women do not disclose abuse to their physician. As a healthcare professional, for those of you listening, you all know that it's tough. It's tough for us healthcare professionals to ask this question to women, to ask this question to anyone that comes into the clinic, simply because it's a sensitive issue. And there's several reasons for this, including potential fear of stigma, further harm, and fear of the unknown. So what do we do as healthcare professionals? What are we left to do to identify victims of IPV? Do we screen all women that enter the clinic? Do we only screen those that are at high risk? Do we screen any women? And what do we use to screen these women? So with all these questions, there's pros and cons. For instance, if we screen all women that enter the clinic, the immediate concern one has is the cost. That could be very, very costly. But the advantage is that there's a high chance you'll identify even those victims that would be missed otherwise. And the second point, do we screen only those that are at high risk? That's a great point to raise, because if you screen only those that are at high risk, yeah, you'll be missing the rest of the population. What do you do with those? And then finally, what we decided to focus on was, how do we screen these women? Do we use a computer tool? Do we give a simple questionnaire? Or do these women fill out a questionnaire with the interviewer? So screening for IPV, there's currently 33 screening tools. That's right, 33. Oftentimes, let's say for depression, you have 1 or 2 screening tools that are standardized that clinicians or physicians use to help identify victims of depression. But for IPV, there's 33 screening tools and scales that exist to positively identify victims, each of which has its own advantages and disadvantages. So as you guys may know, sensitivity and specificity are an important aspect for disease and identification of disease. Sensitivities and specificities differ between all of these tools. So imagine for you guys as the healthcare professionals, which one do you use? How do you even know which to use? So it's a very challenging task, and so far there hasn't really been true research determining which screening questionnaire is the best suited to identify victims of IPV. So why do with so many screening tools, what are we left to do? Which one do we choose? You know what? That's a question that I will never know the answer to, at least not right now. And that's something that further research has to look at. So, but what we do know right now is that there's 3 ways to administer these screening tools. And that's something that we can look at, because obviously there's less of that out there. There's a computerized questionnaire where any patient that comes into the clinic would sit down at a computer and fill out the questionnaire. There's a nurse-physician-administered face-to-face questionnaire where the patient comes into the room and the nurse or physician asks specific questions to the patient. There's also, and finally, there's a self-administered questionnaire. In the self-administered questionnaire, it's similar to the computerized questionnaire. However, it's just a simple piece of paper that the patient fills out. It's not on computer, it's not electronic. So on an empirical level, when you look at all 3 of these, there's advantages and disadvantages to each. Computerized, the most obvious advantage is that it's simple, it's easy to use, but the disadvantage, cost. A lot of settings don't have the cost to supply a computer simply for administration of this questionnaire. And the second approach, the nurse-physician-administered face-to-face questionnaire, huge advantage is that you get that personal connection with someone. But the disadvantage, it takes time. Oftentimes when you come into the physician's office, you will see the doctor or the nurse for 15 to 20 minutes. Administering a questionnaire by a face-to-face method takes a significant amount of time, could prolong the appointment by another 10 to 15 minutes. Self-administered questionnaire, the final one, is theoretically the most simple. It's a piece of paper that the patient fills out on their own. Traditionally, this has been thought to be the most optimal approach because it is not only cost-effective, but it also allows women to have the same privacy that a computerized questionnaire has. But with all three of these in hand, we don't know which leads to the higher rates of disclosure, and that's exactly why we undertook this systematic review and meta-analysis. So as you can see from this triangle, this triangle that I'm showing here, the levels of evidence triangle, systematic reviews and meta-analyses are classified as level 1 evidence. Randomized control trials are also classified as level 1, the level 1A evidence. Below that, there's other types of evidence that often are incorporated into health practice: quasi-experimental studies, cohort studies, case control studies, and case series, for instance. Case reports are less often used nowadays, and same with case series, but they still provide valuable sources of information. And I don't want people to think that meta-analyses are the be-all and end-all. That's not what I'm saying at all. All of these play an important role in healthcare decision-making. However, utilizing high-quality meta-analyses, as Dr. Yost stated, that include randomized control trials, provide greater insights, have greater external validity, and can help better guide healthcare decisions. So what is a meta-analysis? For those of you that don't know, a meta-analysis effectively pools the data from all relevant studies found for a specific research question. This pooling allows the results to be more generalized than they normally would from the results of a single trial. So in essence, what you're doing is you're increasing the precision and size of estimate of an effect. And I'll show you what I mean by that in the slides where we pulled our information. So the question that we decided to ask was to assess what is the rate of IPV disclosure in adult women aged 18 and above with the use of 3 different screening methods. And those are the same 3 screening methods that I described previously: computer-administered self-administered screen, self-administered written screen, and a face-to-face interview screen. So as Dr. Yost stated, the PICO format is a very important format that you all should be familiar with because it helps frame the research question in a specific manner. In our question specifically, the P, which stands for population, was adult women aged 18 years of age or older. The intervention, computer-assisted screening. And the comparisons, self-administered written screening or face-to-face screening. And finally, the outcome of interest was rate of IPV disclosure. And that was our primary outcome. Our secondary outcome was patient satisfaction and ease of use, because these secondary outcomes are just as important as the primary outcome, because obviously, even though an instrument has high rates of IPV disclosure and can identify victims of IPV, they may not be, well, to be blunt, patients may not like it. They may hate it. So what's the use of using those tools? And I didn't include T in ours because T means time frame and time. We didn't have a time for ours. Time for us was immediately after coming to the clinician's office. So this slide does have a lot of information, but what I'm trying to present here is oftentimes in the systematic review and meta-analysis, you have strict inclusion criteria. These inclusion criteria are important to identify specific research articles that are relevant to your review. So for us, it was any clinical trial that randomly allocated adult women aged 18 above to undergo IPV screening using the 3 screening methods that I mentioned previously. Studies with exclusive data on males were excluded. And like I said previously, that was due to the fact that there isn't a lot out there on the male population. This is a significant problem in the male population, but research is still lacking. A healthcare setting was defined to be a general family practice, emergency medicine clinic, women's health clinic, public hospital, specialty clinic, or prenatal and postnatal services. However, I want you guys to note that we use any healthcare setting because domestic violence isn't strictly associated with one setting alone. It's more commonly seen in certain settings. However, it can be seen in any setting, any sort of healthcare setting you may witness it. Studies were also not excluded if they assessed the effectiveness of the screening questionnaire as well. So screening questionnaires, which I'll talk about later in the presentation, include the WAST or the PVS. These are 2 different screening questionnaires that are commonly used by healthcare professionals to identify victims of domestic violence. So the search methods that we used specifically looked at variety of databases. These include Medline, Embase, PsycInfo, CINAHL, which is a nursing database, DARE, and the Cochrane Library. We exclusively, and I recommend this countless times to anyone who's doing a review, use a librarian. A librarian is very important here because these search strategies can sometimes get extremely complex. And me not being able to really navigate these databases and also being technically challenged, it's tough for me to come up with these search strategies. And I'll show you on the next slide what they look like right here. So these are two of the search strategies we use for two different databases. So as you can see, the first search strategy had 35 characters, and it has various terms related to partner violence, battered women, intimate partner violence, domestic violence, female, and the list goes on. And there was also a randomized control trial filter built into this. And so that's why I recommend seeking a librarian's assistance, because a librarian will be able to do this properly, efficiently, and in a methodologically sound manner. To your right is another search strategy that we incorporated into this meta-analysis. In a similar fashion as the first one, you see the same terms. However, it's a shorter search strategy. That's because these search strategies are often built they're built independently for each resource. So we had a separate search strategy for Medline, a separate one for Embase, a separate one for PsycInfo, and a separate one for CINAHL. Two reviewers screen the articles found by these search strategies for eligibility. The reason we used two reviewers was to avoid error and to ensure that no article was missed. And this is commonly done for meta-analyses to ensure that everything is captured and to also ensure that these search strategies are accurate and sensitive. So first we did a title and abstract screen, identified the articles that we thought may be relevant, and then we screened the full text of the articles. So does this search strategy once again? In regards to study selection, two independent reviewers assessed each potential article for inclusion and eligibility. The agreement was calculated between two reviewers through an unweighted kappa. A kappa is a very important measure that's commonly used in systematic reviews and meta-analyses, and it measures inter-observer variation, and it can range anywhere from 0 to 1. A number closer to 1 means that there was little variation between the two reviewers. And it's important to conduct it's important to calculate some sort of inter-observer variability. Kappa is sometimes calculated, so is an ICC, an interclass correlation coefficient. Both of these measures are used to determine whether both reviewers are on the same page, essentially. That's how I like to describe it, because obviously in these types of systematic reviews and meta-analyses, you want both reviewers you want the methodology to be sound. In order for the methodology to be sound, it has to be reproducible. And that's what the kappa is essentially measuring, whether both reviewers adequately understood the methods and did exactly the same thing. Here was an inclusion form that the reviewers filled out, and you can see my initials at the top, NH, and another individual as well helped screen the articles, two independent reviewers. And then if there was a conflict, a third reviewer came in, BP. So this is the type of information we looked at, and this is our criteria for inclusion. For instance, it had to be a randomized trial. However, if it explicitly looked at males, exclude the study. And these forms, generally, they're standardized in the sense where they contain the same sort of information. However, you can make it any way you want, through Word, through PowerPoint, through Excel. It really doesn't matter. But as long as it's consistent, that's all that really matters in the end. So after we identified all the studies, I want to quickly show you guys the study flow diagram of how we came across each specific area. So overall, from the search strategies, there were a total of 746 records identified. Of those, there was a total of 719 unique articles. Of the 719, 709 were excluded. These were excluded through various different reasons, such as non-randomized in nature, there was no screening intervention, and there was no adequate comparator group. Finally, after those exclusions, 10 total articles were assessed for full text eligibility. So the first set of articles were excluded on the basis of title and abstract screen. After that, we retrieved 10 articles and we assessed those for full text eligibility. Of those, 4 were excluded. These were due to the fact that they did not compare two of the interventions of interest, or they analyzed the effects of the screening questionnaires themselves, but not the administration method. Thus, a total of 6 studies were included in the meta-analysis and systematic review. So as I showed previously, right here, for full text conclusion form, a similar form was also created for data extraction. The data extraction form was created and piloted by an independent reviewer. Following this feedback and piloting, the form was used to collect all relevant data from the included studies. The data extraction form for most reviews contains information in relation to total number of participants in a trial, the clinical setting, the screening methods used to compare, the rates of disclosure, and the types of questionnaires used in each method. Information relating to the patient satisfaction and specific intervention, when relevant, was also included in the data extraction form. And finally, all included trials went through a Cochrane risk of bias assessment. The questions in this tool related to randomized sequence generation, sequence concealment, the blinding of participants, blinding of study personnel, blinding of outcome assessors, level of incomplete data, and selective outcome reporting. Once again, just like the study inclusion, a kappa was also calculated to evaluate the agreement of the reviewers on different aspects of the risk of bias. This risk of bias is actually an extremely important aspect of meta-analyses, since on the whole, when you consider randomized trials, they're considered to be high-quality evidence. However, there needs to be certain aspects for a randomized trial to still be considered to be methodologically sound. And these are the questions that are commonly used to assess that aspect. So here were our evaluations. You can see on the left panel, there were 6 studies that we included, and on the top, those were the questions that were assessed. As you can see, all the studies were considered of low risk bias. So the green box, the green plus, indicates low risk. The red box indicates high risk. However, you don't see it here, but some studies also have a gray or yellow box. That indicates unclear risk of bias. So for us, for instance, Chen 2007 had low risk of bias across all the questionnaires in the Cochrane risk of bias assessment tool. However, Furby 1998 had low risk of bias for some questions, but high risk of bias for other ones. These included randomized sequence generation, allocation concealment, and selective outcome reporting. Finally, Macmillan had high risk of bias for allocation concealment. So this type of table is generated by a program called RevMan, and that's what we used. And RevMan automatically populates this table with the question responses that you give it. In order to measure the treatment effect, you first have to know what outcome you're dealing with. Is it dichotomous or is it continuous? If it's dichotomous, you would use an odds ratio, risk ratio, or risk difference. If it's continuous, you could use a mean difference or standardized mean difference. Sometimes people ask, what's the difference between mean difference and standardized mean difference? Essentially, what you're looking at here is so let's say you have a continuous outcome, and 2 different scales are used. If 2 different scales are used, you would use a standardized mean difference because not one common scale is being used between the studies. However, if a common scale is being used between the studies, a mean difference is calculated. Our primary outcome was dichotomous. Therefore, we reported an odds ratio. And I want everyone to note here that we could have easily reported a risk ratio, but due to interpretation, we thought using an odds ratio would be easier to interpret for healthcare professionals. Finally, the assessment of heterogeneity. This is often done in meta-analyses to look at the inherent variability between studies, the differences. And it's evaluated through analysis of the I-squared statistic. And below here, I've copied and pasted an image of the Cochrane guidelines for evaluation of heterogeneity. 0 to 40% is considered to be not important. You don't need to evaluate heterogeneity if it's 0 to 40%. If it's around 30 to 60%, you may have moderate heterogeneity between the studies. 15 to 90% may represent substantial heterogeneity. And finally, 75 to 100% represents considerable heterogeneity. So what's important to note here from this slide is that these are strictly guidelines. Oftentimes, meta-analyses have different sorts of thresholds for conducting heterogeneity in subgroup analyses. And not one approach is more correct than another approach. We exclusively focused on the Cochrane collaborations approach because our review was a Cochrane-type review. So the subgroups are generally determined a priori. What that means is that it's in advance, in the protocol development stage. Otherwise, the truth is that you'll be fishing and you'll be trying to find something. I could do subgroup analyses on the most random facts and find some sort of association. However, it's generally not done because it doesn't make your systematic review robust. For our review, a priori, we decided that our subgroups are going to be based on the type of questionnaire used, whether it was the WAST, the PBS, the HITS, the VAWS, and also the clinical setting, which includes family practice, emergency medicine, the prenatal unit. And we thought that these were important aspects to look at because, like I said previously, there's 33 different questionnaires out there. There's different methods, and each method you can use, each screening method that's out there can be administered through different means. So it's inherently, it's possible that the screening questionnaire itself is influencing the disclosure rate. Finally, the clinical setting, we decided to use that because we felt that, for instance, the family practice setting will have higher rates of disclosure because that's often the first line of treatment for women than the prenatal setting. So we thought that you may see a trend towards more disclosure in those settings. For the meta-analysis and data synthesis, we used a Mantle and Hansel random effects model as there was expected heterogeneity between the included studies. We expected this heterogeneity because of the different clinical settings that we observed and the different types of questionnaires that are used. So in essence, what we decided to do for pooling of the results was 3 individual one-on-one comparisons. One comparison was face-to-face interview versus computer-based self-administered screen. The second comparison was face-to-face interview versus self-administered written screen. And the final comparison was computer-based self-administered screen versus self-administered written screen. So we decided to have 3 one-on-one comparisons. And then from there, we decided to create a hierarchy of which screening tool provides better results than the other screening tools. Essentially, recently, there's been more work done to a network meta-analysis. And this type of stuff would fit nicely into a network meta-analysis. In a network meta-analysis, you don't make these type of one-to-one comparisons. You make a broad comparison. So it's easier to generalize. So once again, back to the study flow diagram, a total of 6 studies were included after abstract, title and abstract review, and full text review. And this was, all these steps were done by 2 independent reviewers. So of the 6 studies that were included, they all were part of various settings, like I said before. They included family practice, emergency departments, the women's health clinic, and pediatric care. The studies were conducted in 3 regions, Japan, the United States, or Canada. 5 studies reported information on patient satisfaction outcomes, but rate of disclosure was assessed by all the studies, which was our primary outcome. And our kappa, something that I mentioned before, which mentions agreement between the reviewers, at the study inclusion stage was 0.8. What does that signify? That there was a high or excellent level of agreement between the reviewers on study inclusion. For the risk of bias assessment, which I mentioned before, it was 0.83, which once again, similar to the study inclusion, represents a high to excellent agreement between the reviewers in regards to the risk of bias of these studies and the individual studies. So here are the results of our review. This is the first outcome was looking at rates of disclosure between computer screen versus self-administered written screen. So this can be seen, let me see if I can get this pencil to work. So right here was a computer screen and then self-administered screen. And as you can see here, there were 2 studies included in this outcome, both of which reported a higher odds of disclosing intimate partner violence using a computer screen. So odds in the Macmillan study were 1.2, and the odds in the merit study were 1.34. Overall, we found an odds of 1.23 with a confidence interval of 0.92 to 1.64. What does that mean? So, oftentimes you look at the confidence interval to determine whether something is significant. For an odds ratio, the line of non-significant is 1, so that can be seen right here. If the confidence interval crosses that line, it means that the result will be non-significant, and that's exactly what we found. With a confidence interval of 0.92 to 1.64, as you can see, the p-value was 0.16, implying that there was no significant difference in rates of disclosure between computer screen and self-administered written screens. The heterogeneity, as I said before, which is measured through the I-squared statistic, was found to be 0%, which is right there. That, although it's 0% in here for this result, something important to note is that there are only 2 studies included for this outcome. Once more studies are included, you're generally expected to get a higher number of heterogeneity. But we were fortunate. We had 2 studies in this outcome, and thus a 0% reported heterogeneity, meaning that there was no significant variation between the studies themselves. For the second one-to-one comparison, so the first one looked at computer screen versus self-administered written screen. For the second one-to-one comparison, we looked at a face-to-face screen versus a self-administered written screen. And here, you can see that there's 2 categories. This is because I'm presenting data on the subgroup analysis itself. So the first overall analysis, so if you just ignore these categories right here, just don't even pretend like they don't exist. The overall estimate effect is right here. And here we see that the odds ratio was 0.82 and the confidence interval was 0.59 to 1.23. This is suggesting that there's a 15% less odds of disclosing intimate partner violence when using a face-to-face screen in comparison to a self-administered written screen. Confidence interval, once again, was 0.59 to 1.23. What does that suggest? A non-significant result, once again, because it includes 1. So the p-value, because of that aspect, is 0.38. I-squared, which is a measure of heterogeneity, was 49%. And a priori, we had decided that our subgroup analysis would be performed when any value of I-squared would be greater than 40%. So here we decided to do subgroup analyses. And that's where these come in, right here. This one and this one. So we did subgroup analysis on the basis of questionnaire used. So we grouped the studies, and if we grouped the studies on the basis of whether the VAWS was used or the WAST or PVS was used. And we were able to successfully resolve the heterogeneity. We found that when the WAST or PVS were used, the heterogeneity dropped to 0%, but the result was still non-significant at 0.91. So the odds of disclosing were 1.02, almost exactly 1. However, we thought when we looked at the VAWS questionnaire, the one study that reported that, we found that they found a significant result of 0.58. The odds of disclosing IPV were 42% less with the face-to-face screening in comparison to self-administered screen. And this was significant at 0.04. Although barely significant, still significant. So that's the importance of conducting heterogeneity subgroup analysis, because it helps resolve the heterogeneity and it helps you shed more insights into the true results. So here what we found was that, yes, the screening tool administration methods do differ on the basis of which type of questionnaire is used. And we can safely say that based on these results. Our final comparison was face-to-face screening versus computer screening. Here we included 3 studies, one by Furby, another by Clevens, another by McMillan. McMillan actually is a researcher at McMaster University. Here, the overall effect was found to be 0.63, so that's the odds ratio. Once again, the confidence interval was found to be 0.31 to 1.30. The p-value was 0.21. So this odds ratio is suggesting that there's a 39% less chance, or 37% less chance of disclosing IPV when a face-to-face screen is used in comparison to a computer-assisted screen. The heterogeneity for this analysis was 37%, which was below our predefined cutoff. So we decided not. So although generally speaking you don't perform subgroup analyses if you define your I-squared, if you don't meet the cutoff of your I-squared value that you defined beforehand, which was 40% for us, we decided to do it simply as an exploratory analysis, and that's what we stated in our review. And here we found pretty interesting results. Based on the clinical setting, you can see that the odds actually changed quite a bit. So when you looked at a women's health clinic, the odds of disclosure were significant at 0.45 and a p-value of less than 0.0001. I-squared, we were successfully able to resolve the heterogeneity. So this result is suggesting that a face-to-face screen leads to 55, the odds of disclosure of IPV using a face-to-face screen decreased by 55% in a women's health clinic in comparison to a computer-assisted screen. In the emergency department, however, the one study that looked at that, we found, although non-significant, a 73% decrease in odds when a face-to-face screen was used in comparison with a computer screen. The p-value here was 0.27. So as you can see, we were still able to bring that heterogeneity down from 37% to 0% based on the clinical setting. So like I said previously, our subgroup analyses were based on clinical setting and questionnaire used, and we were successfully able to use those subgroup analyses to correctly identify what the true trends are. So finally, here's a graph that we constructed that evaluated patient satisfaction. Here, something I recommend everyone to do for meta-analyses is to not exclude any data. Any data you exclude is decreasing your precision of effect. So what we decided to do was create a graph because we weren't able to pool data on patient satisfaction. Patient satisfaction was evaluated by these studies by various questionnaires, various non-standardized questionnaires. Some studies had inconsistent reporting. In essence, that didn't allow us, that wasn't conducive to pooling of the results. So what we did was create a graphical representation of what these studies are suggesting. And overall, what we found was no one stated that face-to-face screening was significantly favored in terms of patient satisfaction, which is quite surprising because you'd think that patients would love to interact with physicians, love to interact with nurses, love to interact with healthcare professionals about their concerns. But we found that studies did not show that. We did find there was no significant difference between the two groups. However, two studies reported that women significantly favored using a self-administered screen or a computer-assisted screen for screening purposes for domestic violence. So that's interesting because, like I said, you would expect that being in a physician's office, you'd want to talk to the physician, but we found that patients, and women in particular, enjoy more privacy, I guess, and privacy in regards to filling out these questionnaires. So the overall message we found based on these results was that self-administered screening tools, especially those delivered by the computer, trend towards higher rates of disclosure and better overall patient satisfaction amongst women in comparison to self-administered written screens and face-to-face screens. And once again, you can see these by these results right here, which I've highlighted in gray all throughout, so maybe tough to interpret, but that's what it's saying. So like I said before, heterogeneity or apparent differences across the studies were found in both analyses that we conducted. There were two of the analyses that we conducted out of three. One was face-to-face interview screen versus self-administered written screen, and the second was face-to-face interview screen versus computer-assisted self-administered screen. So for the first analysis, for face-to-face interview screen versus self-administered written screen, we've resolved the heterogeneity on the basis of questionnaire used. So that was something I described before, right here. So in this analysis, as you can see, we did subgroup analysis on the basis of questionnaire used. And we were able to support our subgroup analysis through research that found that the VAWS was actually most appropriate for clinical settings in Japan. And if you go back to the results, sorry if I'm going back and forth, but if you go back to the results, Katoka 2010 was a study that was conducted in Japan. And this screening tool is most appropriate in that setting, the VAWS. So, and because of that, it's not really, there's no external validity to that tool. It's mainly based for a Japanese setting, and that would skew the results. In our second analysis on face-to-face screening versus computer-assisted self-administered screening, the heterogeneity was resolved on the basis of clinical setting. And that's been reported by several studies, and I've listed those below. For instance, McCloskey et al. 2005 found higher rates of IPV in the hospital-based addiction units in emergency departments. Kovac et al. Found IPV prevalence was relatively small in the obstetrics and gynecology departments at approximately 8%. So in essence, what we were trying to show here is that although we're seeing that computer-assisted screenings provide significantly better rates of IPV disclosure in comparison to the face-to-face screening, it's important to know that it's clinical setting dependent. So certain clinical settings will have higher rates of disclosure in comparison to other clinical settings. So overall, something to note is that for victims of IPV, whether male or female, physicians are often the first and only chance that these victims have to seek help for their problems. Our review suggests a potential benefit of allowing victims the opportunity to complete questionnaires in privacy. Unlike previous thought, like I said before, the self-administered written screen is not considered to be the most optimal strategy. It's actually computer-assisted screenings that are thought to provide, according to the results of this meta-analysis, the most optimal rates of IPV disclosure. So the strengths and limitations of this review, as with all reviews, ours also comes with limitations. Language bias is one of them. We only did look at English studies. Perhaps there are other studies out there in other languages that we did not look at, and because of that, our results are skewed. Publication bias is important because, one, we weren't able to assess publication bias. Publication bias is often assessed through visual inspection of a forest plot, or a funnel plot. I don't know how many of you know or are aware of funnel plot analysis, but it's pretty simple. It's on the basis of symmetry. So when you have I can draw it out here. So let's say we have the x-axis and the y-axis. Your studies are plotted on the basis of effect size. So let's say these are the studies. With higher effects, with larger studies at the bottom, smaller studies on the top. So you evaluate the symmetry of the funnel plot. Let's say all these dots are the studies. As you can see, this funnel plot is pretty symmetrical. That means that there's very little publication bias, supposedly. It's all based on guidelines. However, let's say the funnel plot had more dots on this side. That implies that there's a potential for publication bias because the symmetry's gone. It's asymmetrical. So for us, we weren't able to identify this simply because we didn't have enough studies. As I stated previously, we had a total of 6 studies in our meta-analysis. Ideally, for publication bias, you want to have greater than 10, 15 studies that allows you to better identify the symmetry of the funnel plot. The strength of the pooled estimates is another limitation of our study. We only included 6 studies in our review, of which, as you can see here, the sample sizes were rather low. Only one study had a huge sample size, which was the Macmillan studies. So because of that, the strength of our pooled estimates is actually decreased, simply because our our numbers, our sample size was not that large, overall sample size. Finally, another limitation of our review is that we didn't look at the extent of abuse or violence as a factor. As I stated initially in the introduction, domestic violence is a spectrum. So there could be trauma, broken bones on one side of the spectrum, and on the other side there could be verbal abuse. We weren't able to analyze that aspect. And because of that, we can't say for certain whether there's any differences in these screening tool administration methods on the basis of extent of abuse. One study leads all. The reason why I stated this is because, like I said previously, the results of our review are heavily dominated by one study, which randomized over 2,000 patients. That was the Macmillan study. What are the implications of this? Well, simply put, external validity. We are using the result of one study to drive our effect. And that, in essence, that's decreasing the validity of your results because the other studies aren't getting the equal weight. Finally, what we decided to do was, this was rather new when we were doing this, a grade approach, which grade helps assess the quality of the outcome itself, not the studies, but the outcome. And the assessments are based on the overall risk of bias, inconsistency between studies, the indirectness of evidence, imprecision, and publication bias. Inherently, randomized control trials start as high quality. So as you can see at the bottom, the copy and paste from the grade estimates, high quality evidence are considered to be randomized trials. And then you rate down on the basis of each of these factors. So inconsistency between studies is simply that, whether studies are saying inconsistent results. That can be measured also through the heterogeneity. Indirectness of evidence suggests or looks at whether the studies are evaluating what they're supposed to be evaluating. Publication bias is another aspect which I discussed previously, and imprecision is once again based on the size of the effect. It could be, you can look at imprecision through a confidence interval because larger confidence intervals suggest more imprecise results. So for us, the grade tables I've listed here for each of the outcomes below. So for the first outcome, between face-to-face screening versus computer-administered screening, we found moderate quality evidence, which is stated right here. And there was no serious inconsistencies. There was no indirectness. The risk of bias of the outcome itself was generally low. But we did find imprecision. This was because the confidence intervals were quite wide for most of these studies. And because of that, we rated that down. So there was serious limitations for that. But we still believe that this is a critically important outcome for healthcare professionals to be aware of. For the face-to-face screening versus self-administered written screening, the quality of this evidence was created to be high. And once again, this is of critical importance. With high quality evidence, you see no serious inconsistencies, no serious indirectness, no serious imprecision, and no other considerations. For the third outcome, for the third comparison, computer-assisted self-administered screen versus self-administered written screen, we once again found high-quality evidence with no serious inconsistency, no serious indirectness, no serious imprecision, and the outcome was considered to be of critical importance. And finally, we grouped this outcome this is for specifically patient satisfaction, computer-assisted or self-administered written screen versus face-to-face screen. Which one had better patient satisfaction? And the strength of this outcome was once again moderate. There was rating down here because of the fact that we weren't able to pool this result, as you can see here. Like I said before, we created graphical representation. This was once again of critical importance. So in essence, what we're doing with these grade tables, everyone, is that you're looking at the level of the outcome. Are the outcomes considered important? Yes or no? And are the outcomes of high quality? Yes or no? For us, we found that two of the comparisons were of high quality, and two of them were of moderate quality. So the implications of our results. Healthcare professionals really should consider utilizing more self-administered questionnaires, such as the computer-assisted screening tools, to help identify victims of IPV. Computer-assisted screening tools appear to provide the best results in terms of disclosure and patient satisfaction. However, there's definitely considerations that need to be made. For instance, the costs. Installing a computer in these settings can be quite costly. In addition, there's a learning curve. Oftentimes, even myself, I have difficult time getting used to the computer. Imagine being a patient of an older population having this difficulty. The availability of these computers. Would you want a computer to be in every single clinic? Would you want it to be only in some clinics? Can patients only go to certain clinics to know that they can be potentially screened using these computers? And finally, an important consideration, which is often forgotten, is the rural setting. The rural settings, for instance, I was at a rural setting recently, a rural clinic. The resources are lacking. Can you even have a computer in these settings? Is it better to have self-administered written screens, so paper screens in these settings? According to the results of this review, the computer-assisted screens provide the most optimal results. However, it may not be practical in these settings, in these rural settings. You may not be able to do that. So what do we do here? Is it better here to utilize a face-to-face screen? We simply don't know. And what I'm trying to emphasize is that we need more research into this rural setting, because patients in the rural setting are significantly different in the urban setting. In the rural setting, the patient-physician relationship is also significantly different. So further research needs to look into that aspect. Future research overall need to evaluate satisfaction on standardized tools, which allow for pooling and generalizability. If we go back here, you can see that we weren't able to pool on patient satisfaction. All we can state is that self-administered screens on the whole are preferred over self-administered screens on the whole are preferred over face-to-face screens. However, we can't back that up with numbers. So because of that, I think it's very important that further research looks more into developing standardized tools to look at patient satisfaction. The second point for further research is the standardized questionnaires. Currently, 33 exist. That's crazy in my eyes. 33 tools to screen for a problem, it's mind-boggling. For healthcare professionals, which one do we use? We don't even know. This research sheds highlights into the fact that clearly different screening questionnaires can lead to different results. So I think it's worthwhile for future research to identify those screening questionnaires that have the best sensitivity and the best specificity, and then test those screening questionnaires with these screening tool administration methods, such as the computer-administered screen, self-administered written screen, and the face-to-face screen. The third aspect, I think, for future research is to look at the efficacy of these screening tools in the clinical setting. As we showed through our results, the rate of IPV disclosure differs across clinical settings. So it would be nice to know more about whether this is actually a true difference. Oftentimes with smaller studies, as you can see here, so this study was rather small, and this one right here by Clevens was small, and this one here by Furby was small. So smaller studies, you can see the confidence interval is huge. So we don't really know the true effect of these studies. So it'd be nice to know, to have larger sample studies that evaluate these different clinics to see whether there's a true difference in disclosure rates between these clinics. And finally, the last aspect for future research, I think, is in males. The research in males currently is lacking. We simply don't know the disclosure rates and the sensitivity specificities of these screening tools in males. Furthermore, we have no clue on what type of screening tool administration methods should be used in males. So I think further research should also look into the male population, because IPV and domestic violence are equally as important in this group. And I don't think it should be forgotten that it can happen to anyone. So for further research, I think that's definitely a consideration. I think that's it from me.
Great, thank you so much, Nasir. We will be asking you now, have you changed your mind, or do you still think the same that you did at the beginning of this presentation? So, do computer-assisted self-administered screens lead to higher rates of IPV disclosure compared to both face-to-face interview and self-administered written screens? So we'll give everyone a few moments to go ahead and respond. So we are still seeing strongly agree and neutral. One person has actually strongly disagreed. So we'll let give everyone a few more moments to respond, and then Nasir, I'm going to actually ask you what your answer would be, but please hold while we let everyone else have a chance to answer. So we still have people answering strongly agree, and neutral. We still just have one strongly disagree. Just go ahead and give everyone another couple seconds or so to respond. All right, so while we bring up our next polling question, Nasir, I was actually going to ask you what your answer would be to this polling question.
Yeah, that's fine. Everyone, for this, what we found was computer-assisted screens tend to provide higher rates of disclosure in comparison to both those face-to-face and self-administered written screens. So if I were to choose an answer, I'd say either agree or strongly agree.
Okay, great. Thank you so much. That's really helpful. So now we say, we'll just ask you in general, do you agree with the findings of this review? So with this statement, so we're asking you, do you strongly agree with these findings? So do you strongly agree with the findings, agree, you're neutral, you disagree, or you strongly disagree? So I'm watching most people answer, and again, I'm sorry due to the technology that we have here that you're not able to see what I'm seeing, but everyone now is saying neutral, agree, or strongly disagree. So thank you to everyone that's adding in responses. So we're going to open the Q&A or the chat up for questions. So it's really great. We actually have a few questions that have been posed by our participants today. So I'll go ahead and start and read those out to Nasir. And again, please, if you do have any other questions or comments, please post them in either the Q&A or the chat. So first, Kevin has asked Nasir, does completing privately mean anonymity?
Okay. Kevin, yes. So completing privately does mean using an anonymous questionnaire, making it anonymous. So in a computer-assisted screen or a self-administered written screen, you're doing the question privately and anonymous. But it's important to note that the answers to these questions are still posted in the patient chart.
Great, thank you. And Kevin, you can let us know if that fully answers your question. And we have a question from Emily. How many of the 33 screening tools include screening that is appropriate for and inclusive of lesbian, bisexual, transgender, and gay patients experiencing IPV?
Emily, that's a great question, and if you don't mind, that's something I'd have to look into, because with 33 questionnaires, I even have a tough time keeping up with what each are standardized to be used in. I know, for instance, that the WAST has been the most widely studied to be used in a female population. I don't think they specify specifically which groups to use it in, but that's something I can look into. I know there has been more research conducted recently on the use of simple questionnaires that are based on 1 or 2 questions, simply like, are you having difficulties in the home? Are you feeling down, depressed, or hopeless? Those type of things. But once again, that's something I need to look into myself, and then I can get back to you on that.
Great, thank you, Nasir. And I'm just going to add on to Emily's question. Do you know of a systematic review that's been conducted of screening tools for intimate partner violence?
Yeah, there has been a systematic review conducted on the screening tools, but there hasn't been a meta-analysis conducted, and that's a big difference. A systematic review has been conducted which found that there's 33 screening tools that exist, but there hasn't been any pooling done on these. So there's no estimate of effect of which one provides the most optimal results.
Great, thank you. That's really helpful. So we have a question from Colleen. Was there a particular tool used when screening using a computer versus face-to-face or self-administered?
A specific tool, Colleen, do you mean a specific questionnaire, or do you mean like a type of computer?
Yep, so that's great. So Nasir, we'll wait for Colleen's reply back. So she has replied back. She said yes, questionnaire. Yes,
so actually there was not. So for the computer-assisted screening results, that's exactly why we didn't use subgroup analysis. I just presented these results right here based on the questionnaire used, because the Macmillan study, the Furby study, and the Clevin study all reported results as well on using the WAST questionnaire.
Great, thank you. And Emily has another question. Do patient concerns about negative social response from health professionals, or in other words, stigma, affect IPV disclosure in different settings? So would you would staff training and awareness raising in the community change this data around tool admission?
100% agreed. And that's a great, I think Emily, you said Emily stated that?
Yep, that was Emily.
Yeah, Emily, that's a great point you raised right there, because what you generally expect is that face-to-face screening would be higher. And you'd expect that because it's simply, intuitively, you want a patient to interact with the physician. And I think changing the attitudes about that would definitely affect these results and could flip it on the other side. For instance, I know as physicians and as all healthcare professionals, when you note IPV or domestic violence in a patient's chart, you have to report it. It's mandatory reporting. That's in the U.S. and I think also in Canada. Because of that, there's a stigma attached. There's some victims are fearful of what's going to happen due to that reporting. I think changing that perception and ensuring security, confidentiality, and a team-based approach are key towards fixing that result. Because I, like you, agree that face-to-face screening and changing those perceptions would definitely change the results of this review.
Great, thank you so much, Nasir. I'm just going to continue on in the slides. We'll start to wrap up, but please, if anyone attending, any of our participants has any more questions, please post them. We still have some time for Nasir to address them. So I'll just carry on, but please, again, I'll be on the lookout for further questions that come through. So this is just bringing us back to the model for evidence-informed decision-making. And what Nasir has certainly given us today is that purple circle, the research evidence, to start to help us think about as decision-makers what is the best way to think about screening for interpartner violence. So thank you for your hard work and such a great review. And I think Nasir actually did a really great job about talking about some of the other aspects of the model. So in terms of, yes, computer might seem like the better venue to do the screening, but perhaps it's not available, or as Nasir had mentioned, in what clinics or in all clinics would a computer-assisted technology be available. So I think Nasir has really given us some really wonderful things to think about, because it really is not just about the research evidence. And one of the things that I very much as I love this model, I very much dislike that it shows all of the circles being exactly the same size. But really, when it comes to a decision, the size of the circles changes upon your context. So the research evidence may or may not have as much weighting, may not be as big of a circle in certain decisions that you're making, and some other circles may actually win out or become larger when considering a certain decision, such as what's the medium for screening tools for interpartner violence. So thank you, Nasir, for having done a great job commenting on that. And actually, we just have just to share with you, so thanks for a great presentation, very informative, and for the population and situation that a participant's working for in counseling practice. And a surprising takeaway, as face-to-face is used almost exclusively. So I don't know if you wanted to make a comment about that, Nasir, about that comment from one of our participants.
Sorry, I didn't catch that. Dr. Yost, can you say that again?
Oh, yeah, so one of our participants had just said that, I guess it's a really surprising takeaway, as face-to-face is used almost exclusively in their context.
Yeah, it is surprising, and that's why I agree with what Emily stated, that more training is needed in this field, because face-to-face, even in our clinic in the U.S., I worked at a family practice setting in the U.S., and it's face-to-face screening that's used. And that's why I was even surprised by these results, because you would expect, yeah, face-to-face to be the best and provide the most optimal rates of disclosure, but what we're showing and potentially suggesting is that computer-assisted is better. But I don't want everyone to get caught up in that fact that this is a definite result. Something that I really want to emphasize is that there were there was only 6 studies included in this review. That's a rather small review. We definitely need many more randomized trials on this topic that look at standardized tools, that look at specific questionnaires, and that look at specific clinical settings to come up with a better estimate of effect. Maybe the results of this review are pointing towards the wrong direction. Maybe with more studies we see that face-to-face screening provides the optimal rates of disclosure. But currently, yes, it is surprising. I do agree with that computer-assisted screens are providing better, if not equal, results for IPV disclosure in women.
Great, thank you. Yeah, and I think with that point, Nasir, it's at this point in time right now, your systematic review that you and your colleagues have conducted is the best available evidence that we have at this point in time for decision makers to inform their decisions.
That's exactly right, yep.
So clearly with more research, we can always have a change and a recommendation, but right now, I would say that this is the best available research for us to use as decision makers, so thank you. So just also while waiting to see if anyone else has any other questions or comments for Nasir, just wanted to take a chance to let all of you on the line know about a study that we're currently conducting within Canada, and we're inviting those who work in public health departments or regional health authorities to participate in our study, where we'll be actually pushing out information in the areas of cancer prevention to participants using Twitter, webinars like today's webinars, or tailored messages. And we're going to be doing this over a time period of 18 months. And what we're actually hoping to do is to see if by pushing out the evidence helps decision makers in public health to use the evidence in decision making. And the study has been funded by the Canadian Institute of Health Research. So please, if you're at all interested, there's a link that we'll be posting in the chat that hopefully you can go ahead and take a look and let us know also if you have any questions. And this is being led by myself and Dr. Maureen Dobbins, who's the Scientific Director of Health Evidence. And just to let you know, Nasir, we've had another comment come in from Colleen's, and she says, thank you. Public Health Nursing in Alaska is planning to try computer-assisted screening in 2 locations based on your systematic review, so thank you. I would maybe just ask you, Nasir, do you have any words of wisdom for Colleen as they start to actually do their study?
Yeah, Colleen, I think that's great that you're going to try that out, and I'd actually hope that you can let me know how the results go for that. One word of advice I have for you for computer-assisted screening is that to ensure that you use a well-validated questionnaire for the screening on the computer itself. So of the 30 or so screening methods that are screening tools that are available, make sure you do research into which one is most appropriate for your setting in Alaska, in the Alaskan Public Health Nursing, and then use that for the computer, on the computer itself for patients that come into the practice.
Great, thank you so much, Nasir. And this is just, a call to action at Health Evidence, as I've mentioned previously at the beginning of the presentation today, that we do have a repository of now an updated slide, I take it. We've added about 100 since the beginning slide. I think that was just a typo. We didn't just do that today. But we have over 4,400 quality-rated systematic reviews. So some things that you can do is you can visit the website at Health Evidence. You can register for our monthly tailored registry updates or the newsletter. So that is a push mechanism with which you will actually be receiving information about what are the latest systematic reviews that have been added. Tell your colleagues, share about Health Evidence. You can follow us at Health Evidence on Twitter to get daily tweets related to public health intervention reviews. And you can actually encourage those in your organizations to search and apply the evidence within Health Evidence. And please, as always, contact us to suggest topics for future webinars or to provide us feedback. So I just wanted to, again, thank Nasir for being with us today, and again, thank him and his colleagues for their wonderful work for producing the best available evidence. And I have not seen any more questions or comments come through in the chat or the Q&A. So I will, again, thank all of you for participating today as well. And I will leave the last word with Nasir. So Nasir, are there any last words, a golden piece of wisdom that you would like to share with the participants before we close this session today?
I encourage everyone to learn more about conducting meta-analyses and systematic reviews. I think they are a great aspect, and like Dr. Yost said, for driving practice. You want to use the best evidence for driving practice, and meta-analyses are up there in that aspect. And then once again, I just want to say thank you for everyone for listening in today, and I hope that everything made sense, and if it didn't, feel free to email me with questions. I'm completely open to questions on the basis of methodology, study design, and of this review in particular. So thanks again, everyone, and I hope you enjoyed it.
Great, thank you so much, Nasir. And with that, actually, we'll go ahead and share your email, if that's okay, with the participants today.
Yep, that's fine.
Great. Thank you very much, everyone. Nasir and I will likely stay on the call for another moment or so. But this formally concludes our webinar today, and thank you very much for having joined us. Have a really great afternoon, and best wishes for happy holidays.